This is our first joint seminar between the UNH Economics Department and the Center for Health Economics and Policy Studies at San Diego State. Thanks to my students who are watching this in San Diego at the moment. We're lucky to have Catherine Maclean joining us this week. Catherine's an Associate Professor of Economics at Temple University, also a Research Fellow at the National Bureau of Economic Research and a Research Associate as well at the Institute for Labor Economics. Catherine does work on the economics of substance use and on mental health issues. She's published in journals that would make a lot of us applied economists and health very jealous. Her work has appeared in the Journal of Law and Economics and Health Economics, the American Journal of Health Economics, Health Affairs. We're all big fans of her work. And Catherine's here this week to present some new work, a working paper on access to mental health care services and crime. Catherine, thanks so much for being here.
Oh, thank you. Thank you very much. It's really a pleasure to be here. It's my first time to New Hampshire. It's a beautiful state. I will apologize. I'm a little sick, and I just realized I was snorting into my microphone, so I apologize to people for the snorts. I'm just overcome. I'm not bringing the outbreak from Philadelphia, though. So I also want to say I'm a huge admirer of Joe's. So thank you for the kind words. I followed Joe's career and really look up to him and think he's just such a great researcher. But thank you for having me. So this is new work, and it is access to mental health care treatment and crime. So I first want to acknowledge my co-authors. I'm very fortunate to work with Monica Deza. She's a great crime economist at CUNY Hunter, and I'm also really proud of Keisha Solomon. She is a Temple PhD student who just defended, and she's going to be starting her career at Johns Hopkins, so really excited for her. And we are working on this paper. It is very preliminary, so I'm really looking forward to your feedback. This is a time when comments would be most welcome. So just to talk a little about what this paper is, just to give you a preamble in case you have to leave early, what we want to look at is what is the effect of access to mental health care treatment and crime. And I'll talk later about what we are able to measure with access. Access is a very broad construct. We're going to be able to capture potentially one margin of that. So I've got my deep theory right here with the arrow diagrams. I'll talk more about this, but essentially what we think is going to happen is we think that when there's an increase in access to treatment, as we measure it, this is going to lead to an increase in treatment use, which is going to lead to a decline in mental illness and potentially lead to changes in crime outcomes. What the type of healthcare that we are going to be talking about is we're going to be thinking about offices of physicians and non-physicians. And I'll spend a little more time on this later, but we're going to be looking at the openings and closings of these offices in counties. And that's going to be our measure of changes in access to treatment. So it's going to be the number of offices. That's going to be beneficial in many ways, but it certainly has its limitations. Our local area, in our main analyses, we're going to look at the county as the healthcare market. And of course, not surprisingly, with this setup, we're going to be estimating a differences and differences style model. So we're going to be identifying off changes. So it's going to be really important for us to think about why are we observing changes in this treatment outcome. The crime rates that we're going to be looking at, we're going to look at total crime, violent crime, and non-crime using data from the FBI that many of you are probably familiar with. And going along with our deep theory, right now we're also going to be looking at proxy for mental illnesses, which is suicides. We're hoping to bring in some treatment to try and provide more motivation on this causal chain up here, but the paper is a little more preliminary than allows us to do that. So just to give you a preview of the results, what we're going to find is that when there's an increase in the number in access to mental health care treatment in the area, we're going to find a decline in total crime rates, violent crime rates, and non-violent crime rates. What we're going to see is that these effect size are relatively modest, but given some of the high costs of crime, we still think that these are potentially valuable changes that we're observing. And we're going to see that the effects are predominantly driven by non-physician offices, not physicians, which was somewhat surprising to us. So we'll try and think about why that might be. And our effects are larger in relative size for changes in violent crimes rather than non-violent crimes. So we're trying to think about what that might mean. We also see that as the number of healthcare providers increases, we're going to see declines in suicide rates. So these findings are suggestive of a potential secondary benefit from expanding access to mental health care treatment in terms of reduced crime. Because if you think about it, these offices are primarily there to allow patients to access treatment and improve their mental health. But we're seeing these potential spillovers to crime outcomes. So the talk is going to take a very standard approach. And just to give you some, I want to give you some backdrop on mental health care, and also sort of concerns about mental health care, mental illness and crime. So public concerns, and what we're thinking about here is sort of discussions in the public about the relationship between mental illness and crime. It sort of varies over time. When crime rates are high, there tends to be more discussion of are those with mental illnesses, are they more likely to perpetrate crimes, and is this a danger to society? When crime rates decline, maybe we're not as concerned about this potential link. So we're just thinking here about the concerns amongst the public for this potential link between mental illness and crime. In the 1960s and 1970s, there was the state mental health hospitals, so these were psychiatric hospitals for the mentally ill, were closed and otherwise downsized. This was part of the overall movement towards deinstitutionalization of mental health care, which is a movement that other scholars have tried to understand. That's really beyond the scope of our paper. But what this did lead to is sort of a displacement of mentally ill patients who previously would have been hospitalized or institutionalized. They were now living in the community. And this raised concerns amongst the public. Are the mentally ill a risk to the public? That is, are they more likely to commit crimes than non-mentally ill? Advocates at the time said, no, that's not the case. Those who are mentally ill are no elevated risk of committing crime than those without mental illness. But there was really not very much credible evidence on this at the time. During the 1990s, there's a well-known stylized fact that crime rates declined over this time period. Over this time period, there was less public discourse about this concern that the mentally ill were more likely to perpetrate crime. At the same time, this was an important period in advancements of pharmacotherapies or medications used to treat mental illnesses. So this was a big upgrade. There's innovation, and there's just increased utilization of these medications. And there's some studies that I'll talk about a little bit later, but there's evidence that these increases in utilization of mental health care treatment led to a decrease in crime. And with the very sad recent violent mass attacks, such as mass shootings in the United States and many other countries, there at least has been within the media, and I'm not saying that is the correct metric along to which to rate causal inference, but there is sort of anecdotally that many of these events may be linked with mental illness of the offender. So what we're just trying to say here is that there is more at this time because of these recent events. There seems to be more discussion within the public. Are the mentally ill at potentially elevated rate? Are they more likely to commit crime than the non-mentally ill? And should we potentially reconsider the idea of providing treatment or somehow addressing the mental illness? Now, of course, the debate within the mental health community about whether or not these events are causally linked, these events that I'm mentioning here, this is certainly debated. And we're not getting into this debate. We're just saying this is raising the issue yet again. And that is what we're sort of using as this kind of another reason why we might think this is a potentially important question to study. Now what I'm going to talk to you about is evidence on the link between mental illness and crime. So first, what I'm going to talk about is just sort of evidence based on the characteristics of these conditions and how they might predispose individuals to be involved in crime. And then what I'll mention to you is I'm going to mention a couple of studies out there, focusing predominantly on economic studies, just because there's huge literatures out there, but that is what we're focusing on. So when we think about features of mental illness, and of course mental illnesses display different symptoms across the illnesses and within an individual. But there are many common features of mental illnesses that could increase the propensity to commit a crime and also to be a victim of a crime. When you think about offending, so being more likely to commit a crime, there are many cognitive limitations that are imposed by mental illnesses, and this may lead to maladaptive conduct. So for example, an individual with a mental illness may interpret a small disagreement as a very large disagreement, and this could lead to a violent outburst or a feeling that this conflict really requires a strong response by the individual. Medications themselves have some serious side effects, which we might think predispose individuals to commit crimes, such as insomnia, aggression, decision difficulties, so on and so forth. Mentally ill individuals may have problems establishing solid employment propensities or probabilities. So they may just have less ability to participate in paid employment, and this may lead them to substitute into illegal employment, where we might think about financially motivated crimes. Many individuals with mental illness use substances to self-medicate their mental illness, and there is some literature out there that suggests that substance use is linked with crime. So there's a range of reasons. We might think that those with mental illness are more likely to commit crimes. Yes.
So I'm just sort of thinking about homeless advocates who make the argument that, you know, we criminalize homelessness and
Yes.
you know, sort of loitering, trespassing,
Yes.
Things like that. Is that, you were going to get to that?
I think that's a great point. So can I go to victimization? Then I'll come, because it's a really good point, and I think that's a very important point. And I agree with yes. So in terms of victimization, we might think that these same features of mental illness might predispose individuals to see those with mental illness as easy targets. So they may just be more likely to be victimized. And coming back to this very good point, there's an idea that has been this criminalization of mental illness. So this is that having a mental illness influences the propensity to be incarcerated rather than crime per se. So thinking about the homeless, which is a very vulnerable population, it's difficult, of course, to quantify outcomes amongst the homeless because they're harder to contact, but it's believed that mental illness prevalence is quite high among the homeless. So we might think that there's overlap here, but this is the idea that a mentally ill individual and a non-mentally ill individual who are engaging in the same activities, the police may just be more likely to to incarcerate the individual with a mental illness simply because of these other features that are displayed with their illness. So we're not going to tease these out, but we do think that this is some suggestive evidence that features of these conditions could lead to more crime outcomes among those with mental ill, being as offenders or victims. There are two economic studies of which we are aware that have looked at this question. So we think that we're going to build on this literature, hopefully. So there's a paper by Marcotte and Markowitz. They look at the increase in prescribing of psychotropics. These are medications used to treat mental illness over the 90s, and they show that this led to a decrease in crime. There's also a nice paper by Coulier et al. That looks at increases in state Medicaid expenditures. And I'm going to show you a little bit later on, Medicaid is a very important payer in the delivery of mental health care services. So increases in Medicaid state spending and psychotropic prescriptions for stimulants and depression lead to reductions in violent crime. So our contribution is to look at a measure of access and how that leads to changes in crime. There's also two very nice papers that are very recent, and they look at changes in access to substance use disorder treatment and show that increased access leads to reductions in crime. This paper here is Jason Lindo is another author, and he is going to be visiting next year, I saw, so we've followed along from their work and learned a lot from them. Something that is important to think about in the context of mental illness and in terms of substance use disorders is the comorbidity. These conditions, for reasons that some are known, some are perhaps not known, they tend to display within the same individual. It's estimated that 50% of those with a mental illness will at some point in their life also have a substance use disorder. Now, whether this is just some other factor, whether it's causal, whether it's self-medication, what it might be, these two conditions are very tightly linked. So when we think about looking at the measures of treatment access that we're thinking about in this study, or these other papers, the Wen et al. And the Bondurant et al., there's so much co-treatment of these conditions by the different providers. I think it is a little bit hard to tease everything out, but what we are thinking is that we're looking at providers who are most likely to provide mental illness treatment with the knowledge that they could also be providing some substance use disorder treatment too. But I think that's just a feature of studying this healthcare type. Yes.
So thinking ahead to what you've described as the experiment, the access measure you're going to be using, what do we know about the marginal patient who seeks out access, seeks out services sort of at these centers, versus those who don't, and what
Yes.
we expect about sort of propensity for illicit behavior?
Yeah. I think that's a great question, and I'll try and address it a little bit later. But I think what you hit it on the head. When we're not focusing on people who are going to long-term rehabilitation centers or psychiatric hospitals. We're looking at offices of physicians and essentially therapists. So the type of person who is going to seek that care and also is going to be marginally induced into and out of care because one of these offices opens or closes. These are probably not the individuals who have the most severe mental illnesses. So, and I think that's why our coefficients are relatively moderate in size, because we're not looking at those who have the most severe mental illnesses and are potentially in different treatment modalities. And I'll come back to that in a second, but I think it's, not in a second, a few more slides, many more slides, but I think it's a really good question when you're thinking about who is the late for us. Okay. So there is a large literature that we address in the paper that shows that numerous modalities of mental illness treatment are effective. That is, they help people manage their mental illnesses. Their hospitalizations, so this might be a psychiatric hospital or a community hospital, long-term rehabilitation centers, and psychotropics, which are again medications used to treat mental illness, and counseling. So I have used red here because when we're thinking about the type of treatment that we are looking at, this is office-based care. It's not specialty care. We're not looking at hospitalizations. So we think, of course, our data is not fine enough that we can see exactly what these providers are doing, but based on the literature, we're going to be looking at essentially psychotropics and counseling and their interaction. There's also evidence based on survey data from the National Survey on Drug Use and Health that treatment is potentially underutilized. There's a statistic that about 50% of individuals who would meet diagnostic criteria for a mental illness don't receive any treatment in the past year. Of course, there are myriad reasons why individuals with mental illness or who screen positive on one of these diagnostic screens in a survey setting do not seek mental illness treatment. We're not saying we're explaining it all, but one commonly cited reason is you can't find a provider. So we're going to be looking at changes in access to providers, which might be influencing those individuals who are not seeking treatment because they can't find a provider. Also, there are mental health care workforce shortages. A paper by Thomas et al. Suggests that 77% of US counties are have a mental health care workforce shortage. How exactly that black box comes together to come up with that specific number, this is a collection of need for treatment, number of providers, cost, so on and so forth. And also, I realized at the last moment this is a typo, 50% of psychiatrists are expected to retire by 2025, and the new supply of psychiatrists is not keeping up such that these psychiatrists who are retiring can be replaced. So there's a lot of evidence that there is mental health care workforce shortages and unmet need for treatment. And we're looking at changes in access. So we think we might have something to say about these questions. So I also must say I recently learned how to change font color in text. So there's probably too much color, but I was quite amused by being able to do this. So there is limited use of voluntary treatment, which is what we are going to be looking at within the criminal justice system. There are involuntary commitment laws. These are state laws that give judges a substantial amount of authority to compel those convicted offenders to seek mental health care treatment as part of the sentencing. The effectiveness of these laws, people have looked at them. We only touch on them lightly in our paper, but they are relatively hard to assess because the effectiveness of these laws, we're generally observing patients with pretty severe mental illness. They're also in specific treatment modalities, and these are also patients who do not want to seek treatment. They are being told by a judge that they have to go to a long-term rehabilitation, whether they want to or not. While it's beyond my expertise in this paper, there's certainly a lot of discussion within the psychiatric literature that for both substance use disorder and mental illness, that involuntary treatment is not something that is really advised by providers. So we just might think any evidence that we can glean from these involuntary commitment laws may not be fully reflective of the value of mental illness treatment. There are also just general concerns among the public health community that the criminal justice system in general is not really doing enough to provide behavioral health care treatment, SUDs, and mental illness treatment to incarcerated populations. So not just to give you a little bit of background on mental illness treatment, you know, how we pay for it, how much we pay for it, and then the last slide of these pretty graphs from SAMHSA, I'm going to try to argue that the type of mental health care that we are looking at, while the marginal patient is potentially different from the average patient, it is at least an important component of the mental health care delivery system. So what I have here, these are just expenditures on mental health care treatment within the US beginning in 1986 and continuing through to 2014. I think 1986 is at least the first year that SAMHSA, the Substance Abuse and Mental Health Services Administration, began tracking this information. So what we can see is we can see changes over time and also in who pays for treatment. So in 1986, there's about $32 billion allocated towards mental health care treatment in the United States. By 2014, this value had increased to $186 billion. I believe SAMHSA puts these in real terms, but I'm not 100% sure on that. Now, what we can also see is there has been a change in who's paying for treatment. So over time, this sort of orangey color here, this is Medicaid. So in '86, Medicaid was paying for about 17% of mental health care treatment in the United States. By 2014, it is 25%. You might think some of this is due to the ACA, given that those on expansion plans were at elevated risk for mental illness. But we are seeing this sort of change over time, but it's not monotonic. We see a bit of a big blip up here in the early 2000s. We also see an increase in private pay. So private insurance and public insurance is paying for more of treatment over time. And what we're seeing is a decline in individuals self-paying and in states and local governments financing these services. Yes.
Do you have any sense how this looks at the county level when this is like in terms of the services? Like, are these people that are going, is it mainly through like Medicaid, or is it more private, you know, employer-sponsored health insurance or something like that?
We don't have that. We do not have that in our data, unfortunately. But I think this picture is pretty reasonable in that Medicaid is paying for a pretty big chunk, and private insurance is paying for a pretty big chunk. But over a steady period, we are seeing like this, I think of this decline here in the state and local governments. From what I've seen across, not this data set here, but other data sets, I think this is this is relatively homogeneous. Of course, you might think due to sort of features of the local healthcare market, maybe more conservative states or counties, this may look quite different. But I think on average, the average is as useful as the average is. I think this provides a pretty good picture. Yes.
When you talk about mental illness, I'm wondering, and I guess it doesn't matter much for your data, but to sort of parse things out by different types of conditions, right? Like you mentioned that anxiety or mild depression might be very different than severe depression or schizophrenia.
Yes.
In terms of sort of links to crime and so forth. And,
yes.
And you know, I sort of thinking ahead like Joe was, I'm not sure that it's something you can do anything about, but the marginal patient might be more likely to be on you know, one end of that spectrum than the other.
Yes.
And I don't know if there's any way of getting at that, or if there's even studies which parse this out in the way I suggested. You know, I have no idea if I'm right. I think
you are right. And I do think, though, that I think that overall, sort of the distribution is going to change. I think that many mental illnesses can, at some point, and I'll come back to that in a minute, be treated in the types of settings that we're looking at. So taking your point, schizophrenia is probably differentially related to crime than something like anxiety. And I think by the time that we would observe, and we don't observe them, but the time a schizophrenic might show up to be receiving treatment in one of the facilities that we're looking at, this is probably a relatively well managed case of schizophrenia. So I'm not sure if we can get at it in our data or at the county level, but I do think that in general, these conditions can be treated in the type of facilities we're looking at, but certainly not when they are having acute onset of schizophrenia. Yes.
Do these numbers have like the expenses for psychiatric hospitals embedded in them? I mean, just because the public sector doesn't have.
Can you give me 2 slides?
Yeah.
I'm not going to give you exactly what you want, but I'm going to try and get close.
Yeah, that's
okay. So this is just what payment looks like. And quickly, the next slide, this is just showing growth over time for all healthcare expenditures and mental illness, mental health care. So what we can see is generally there is some tracking of these two types of expenditures, but they do deviate. And one thing I mentioned earlier when I talked about the 90s being an important period in which there was increased expenditures for mental illness, we do see sort of increases in psychotropics. We're showing increases in some part of the 90s, but not all. Yes.
Just a quick question on your prior slide. So
Sure.
are military payers, the VA and TRICARE and things like that going under other federal, or are they not part of that?
I think they're under other federal.
Thank you.
Yes. Yeah, no, that's certainly they're important payers here.
Thank you.
So this may be what you're looking at. So not exactly what you want, but I think it's the closest to what I have on hand. So what I have here, this is a breakdown of expenditures by different type of providers in 2014, which is the most recent data I was able to find. So what we can see is certainly hospitalization care, which I think you may have mentioned. This is certainly important. It's about 27%. And then we've got specialty centers. I'm pointing these two out because I'm going to return to them later on in the presentation. They're about 14%. We've got some administrative costs of insurance for 9%, long-term care 7%. And then what we have here, retail prescription drugs 27%, office-based professionals for 17%. And if my math is correct, those two numbers are going to add up to about 44%. So we think that the type of care that we are going to be looking at with our offices of physicians and non-physicians, this is the type of care that we are going to be thinking about. So this is probably an overestimate, but we are arguing that we are spending a non-trivial amount of money on this type of care that we are studying. And we think, and retail, if you're thinking about specialty facilities and hospitals, they're typically not getting prescription drugs from retail pharmacies, they have institutional pharmacies. So we do think that we're able to capture at least a relatively important component of the healthcare delivery system.
What role do the various mental health parity sort of acts play over time that were enacted both at the federal and the state level in terms of affecting access and maybe the delivery mechanism?
I think that's a really important question. I will say we don't see any effect of the parity laws on crime, but it may just be, parity laws I've studied them before in other contexts. They're kind of hard to study because they only affect a relatively small share of the population. But Keisha, my co-author, she looks at the effect of the parity laws on mental health illness among young adults, and others have as well. We certainly see improvement in mental health outcomes, and other people like Colleen Berry have definitely shown that once a state parity law passes, there's increase in utilization and sort of shifting of finance, and there's also shifting of finances from individuals to the private insurers. So I think there's a role. We're not able to say a lot in this context other than looking at what others have done. So now I'll just try and move along. I do talk too much. I spent a little bit of time on our deep theory, which is the arrow diagram. This is kind of where this is where we get our conceptual framework. And I will say this conceptual framework was developed for substance use disorders. We think that it is potentially useful for thinking about mental illness, but you can tell me what you think. So there is the Goldstein 1985 tripartite model. This was developed to think about why there might be a drug-crime nexus. If you haven't read this paper and you're a crime economist, you really should read it. It's a fascinating ethnographic read. So there are three hypotheses for the link between substance use or drugs and crime. There's the pharmacology. This is that using drugs leads to intoxication. It minimizes your ability to weigh costs and benefits of actions, hence you're more likely to participate in crime. An economic motivation, it may be that to support your substance use, you may commit crimes, financially motivated crimes to support the cost of the drugs. Also, there's the institutional hypothesis. This is when you are engaged with the illegal labor market through a range of activities, like when you are procuring your drugs, being involved with the illegal market sort of lends itself to prompting you into crime. So what we think that the pharmacology and economic motivation may be useful, or for at least motivating this study, because as I mentioned to you earlier, there are many sort of characteristics of mental illness that you might think lead to similar changes in decision making as intoxication. If you think about cognition problems, and just hallucinations and other types of symptoms that make it more difficult to weigh cost and benefit. The economic motivation, we do think that if those with mental illness are less likely to participate in the legal labor market because of their cognition and other challenges that they're facing, they may be more likely to get involved with the illegal labor market, and commit crime. So I think this is useful for thinking about the link between mental illness and crime. And then what we do is we take a recent paper by One et al. That's looking at access to substance use disorder treatment facilities, and sort of use this to devise a conceptual framework. And all that we do is we just have a number of equations, then we do some substitutions and say, here is our reduced form. But it really is sort of summed up in the deep theory that I showed you on slide 1. So what we have is a structural crime rate equation. So this is crime in county J and time T. We just say it is a function of mental illness of the offender, and mental illness amongst potential victims, and then some shifters for the offenders and for the victims, and we've just got some sort of policing variables at the county level. We can just write mental illness for the offenders as a function of the number of providers in the area, and we can do something very comfortable for victimization. All we do is we take these two equations, plug them in here, make some simplifying assumptions, and what we just say is we see that crime in county J in time T is a function of the number of healthcare providers, other characteristics that predispose people to mental illness, and sort of some area level variables. And I think I might have forgotten my P. I did. There should be a P in there as well. So we see this as a useful reduced form approach. We certainly acknowledge we're not going to be able to tease apart changes in offending and propensities and changing in victimization propensities, but we do think that having a first look at whether if there is a change in access to treatment, whether that leads to aggregate crime rates, is a useful starting point for thinking about this question. But we certainly acknowledge we'd love to tease out these different equations. So our crime data, getting into the data, we are using FBI crime reports. These are reported offenses. So they are offenses known to police officers. I just call them crimes, but that is what they are. They're offenses known to officers. We are going to use county level crime rate data from the ICPSR. This organization makes relatively clean extracts of the FBI data. We're going to follow Friedman and Owens, and we're going to retain only those county year pairs that have no more than 50% of the data imputed. The ICPSR does a lot of sort of imputing for missing information, but other scholars have suggested maybe you shouldn't use that data. We also exclude a very small number of counties that have had substantial boundary changes over our study period. We don't feel confident sort of linking them to linking them across years.
A question about
Sure.
reported offenses. Is that by individual? How many people are involved in a given offense? So
That's a good.
and does that influence reporting? Because if it's a city and there's a big offense and multiple people, there's a report calculated for each individual that reports that same crime versus a rural area where it could be all one event.
Yes.
So do you have any?
I think it's for the offense. That's my understanding. I will say Monica is the crime data expert. That's my understanding, and that's a good question. I think it is the offense.
As long as you write it down, then I'll feel happy.
Okay. No, it's a good one. You write the good
That
ones
might
down.
just explain some rural
Yeah.
differences.
Yeah, sure. And we haven't teased that out. We haven't looked at that, but it would be interesting to look across urban rural. Yes.
I was just going to say, I know it's not UCR, but in the 9 research is also collected by the FBI. It's on the incident basis.
Is that what it is?
So it would be
If I'm wrong, if others know more about it, please correct me.
multiple offenders to an offense.
Mhm.
But say there were 3 offenders of the same offense, that offense is just counted once.
That's it. You, I think you know more about the crime data than I do. Yes.
Can I ask, I mean, you had your theoretical framework, but you didn't talk about economic rationality. I think a lot of the theory of crime is that criminals are mostly economically rational, whatever they may be psychologically. So, but for the extreme mental health situation. So most of this mental health stuff where people are making like good opportunity cost decisions, I mean, some of them are probably wacky, but they get hospitalized, right?
Yeah, I definitely, I think people are rational to an extent. I think that my take on reading, and this is from reading more clinical work and not economic work, I do think that it's easy to think, for me to think, that maybe some of the weighing of the costs and benefits could be changed if you have mental illness. And also, I think if we're thinking about financially motivated crimes, that could be a very rational decision.
I'm not sure. So is it like 80% sort of economically rational in a broad sense, or is mental health? I mean, mental health is usually the exception, I think, of the rationality hypothesis in crimes. I'm just trying to figure out where in your theoretic, you talked about having deep theory, but I didn't hear anything about optimization or not.
Maybe it's not as deep a theory as you might like. We don't have an optimization model in the paper, but we're thinking about the sort of the changes in the access. But we could think more deeply about that.
Okay, I just was wondering.
Okay, so we are going to, we look at part one crimes. We're going to look at total, nonviolent, and violent. We're going to mainly focus on aggregate measures of crime, but we are also going to pull apart the measures and think about specific crimes, and we're converting these to crime rates per 100,000 county residents covered by the UCR data, the Uniform Crime Reports. We are going to get information on mental health care facilities from the U.S. Census Bureau's Community Business Patterns, or the CBP. This is the universe of known establishments to the U.S. Census, and we're going to focus on establishments of physician and non-physician physicians and non-physicians providers who are specializing in mental health care treatment. Just to define what an establishment is, the U.S. Census says an establishment is a single location where an office or business is conducted, or where services or industrial operations are performed. We think about this as a unique office where there are physicians practicing or non-physicians practicing. So when we think about a physician, this is an MD or a DO who is specializing in mental health care, like a psychiatrist. When we're thinking about non-physician offices, we're thinking about psychologists, social workers, so on and so forth, other types of therapists. So to me, the big distinction is the physicians have an MD or a DO. They're going to be able to prescribe medications. In most states, as far as I'm aware, if you are a therapist or if you are you are not able to prescribe medications, and these providers are going to rely more upon therapy-based treatment.
The decision of how to classify the providers who have both, who have physicians and non-physicians. How do you decide whether that is a physician established or a non-physician?
We have no decision. What we do is we use NAICS coding, and there's a separate code for physicians and for non-physicians. And so it is how the combination of U.S. Census and these providers are identifying themselves. So we unfortunately we look at their definitions and have to take that as given.
So is the physician have to be a psychiatrist?
Yes, they have to be.
Psychiatrist.
Yes, or they have to be either a psychiatrist, or they have to say that they are specializing in mental health care treatment. So you could potentially think about someone who is not a psychiatrist specializing over time in that area, but they have to report that they are specializing in that area, or they are a psychiatrist.
Well, I'm a GP, but I've got a nurse practitioner who specializes in mental health. That would be classified as?
I'm thinking they're going to be in the physicians.
So 99 for 2014, you'll have the American Community Survey,
Mm-hmm.
early version, the 99 version of it. And so you could potentially have self-report of occupation. By county, it would be rough without I don't know if the occupational they give.
I was going to ask you that. I was going to ask you this. I have a memory that we've looked at this, and I'm not sure if we can break the codes down sufficiently to tease out these two. But
you might have to get the actual the in-house data. Census in-house data.
Was that through an RDC or?
Yeah.
Yeah, we could think about that. Yeah, after you saying, I'm pretty sure I've looked at this in the public use data, and I don't think I was able to separate the two. But that would be something that could be useful.
You might get down to the 4-digit
level.
It wouldn't be NAICS, it would be SOC.
Yeah. So we cannot, due to changing in the industry codes, we can't separately identify mental health care providers before 1998. They just use a different type of code, and they weren't sufficiently fine. And as I'll show you later, we're going to lag the provider measure 1 year. So this is going to lead us to start our study period in 1999. And then what we view this as a proxy for access. So being able, and I mentioned this earlier, access is comprised of various things. It's ability to pay, it's transportation, it's many, many, many things. It is not simply the number of providers that are in a particular healthcare market. That is what we are focusing on. So it is one dimension of access, and we're thinking about changes in utilization of treatments for those people who are induced into and out of receiving care in these types of facilities when offices open and close. So that's an important thing to think about. We're not capturing a more broad sort of measure of what is access. We're going to estimate a very standard differences in difference style model, or what we're going to do is we're going to look at crime rates in county I, in state S, and time T. We're going to look at as a function of the number of mental health care providers in that county and state lagged 1 year. So what we want to do in the specification is allow for some time delay for treatment to be received and for it to potentially to lead to changes in outcomes. And we have, I'll show you a little bit later, we look at some dynamics, and it's something we definitely want to build on more in the paper to see if we need a longer lag structure.
All the mental health I've been involved in, it's taken a long time. So.
We looked at a couple of years.
It's a joke. But yeah, you're right. Lag
Yeah.
structure.
Yeah. So what we also do is we just got some covariates at the state level, also at the county level fixed effects, state by year fixed effects, and this is just an error term. So what we're going to do is we're going to look at total providers, and then we're going to separate these two types of providers into physicians and non-physicians, because as I mentioned, there are different types of treatment that these two types of providers can provide and are more likely to provide. We also might think that there is selection by patients into the different types of providers. We might think that potentially those patients who would prefer medications will select into seeing a physician who can prescribe the medication. We also might think that there are differences in just sort of ability to pay across patients. Psychiatrists tend to be more expensive than non-physician providers. So we just want to look at these two types of providers. In the main model, we're just estimating OLS. We're weighting it by the population that is covered by the UCR. I had some talks earlier. Maybe pushed me on, maybe we should consider some other models. Yes, we are. We're just in the middle of the paper, so these are all things that are good comments and we are definitely thinking about. And as I said, we are leveraging this within county. The number of providers changes over time. So this is coming from openings and closings of these facilities. Also, mergers. So mergers are an issue in our data. We can't really say much about it. If two providers merge together, we're going to count that as one closing because we just see the number of providers in a county. Now, is that a good thing? Is that a bad thing? Ideally, we'd love to be able to measure the mergers, but you might think if there are mergers, it may make care a little bit more difficult for some individuals because care is now only in one location, and that may have some different transportation implications, but nonetheless, that is what we have in the data. Now, it's really important to think about, is this a suitable type of variation to use for our study? Where many of us are economists, we think about, why might we observe a healthcare provider open or close? It may be due to demand and supply factors. So we may be concerned about reverse causality. That is, crime's increasing, so we see more physician offices open. We try to test this out in the data, but that is something to keep in mind. We're exploring some different things we can do. We're not sure if providers are going to see markets where crime is increasing and then they're going to go and open, but you could certainly tell some more indirect stories as to why this might be a concern, and we're definitely trying to get at this as best we can. We'd love to have an instrument, but we have not been able to think of a good one yet.
Should drop Florida and Texas as outliers.
Oh, yeah? Yeah.
I was just curious, sort of descriptively, when you looked at sort of factors that, observable factors that were associated with openings and closings, sort of what did you see?
With that, this going in the paper, we've looked at it very descriptively, kind of, sort of area level, like population, things like that. Nothing really jumped out at me, but it's something we need to put into the paper and so we can talk more about. But it seems to me more just sort of demographics that didn't immediately jump out to me as a clear pattern. But that is, we'll go in the next version.
Just to a lot of, if you're getting psychotropic drugs, many times the clinician, the physician that's prescribing will require you to see a therapist. And so there's kind of correlation between the two, or one is necessary for the other.
Yeah, I think you're right. I think there could be some, they're complements, not substitutes.
And so some of the merging, at least in a few practices I know in the Boston area and here, have been to make sure that everybody has prescribers in the same building. And it's not necessarily physicians as much as it is physician's assistants, and a lot of, I mean, that's probably more recent. In 2014, that's probably may have happened elsewhere, but here it's really very recent.
Yeah, and I think that's a really important question, and I do think, and I think this is exciting for the field. I think it sounds like you may have a lot more hands-on knowledge than I do, but I think that there's been a lot of innovations. And talking with providers that I know, like there are a lot of changes that have come along with the idea we need to better integrate mental health care and substance use disorder with primary care. So I think that's a lot of that is, as you say, happening now. We should definitely think about that in our context, in our setting, but I think things have changed a lot over this time period, but there certainly could be some interplay between the two. So we cluster standard errors around the county, pretty standard in the style of study. So I'm just going to show you some trends really quickly. All I'm going to show you is that we're seeing crime decline. The y-axis is perhaps not ideal, but we are generally seeing declines over. Sorry, it's an early paper. We're yeah, I know it's going to. So we really need to scale this a bit, but I guess that was what Stata thought was optimal, but perhaps is not optimal for presentation. So all I'm going to show you is that over a time period, we are observing the declines in crime that others have documented. So there's not something completely crazy that we've perhaps done. So what we see is just declines in all three types of crime rates. And next, to kind of try to give you a little bit of information on what the level of variation that we have in our outcomes. That what we're doing here is we're just looking at the average year-to-year change. So we lose 1 year in the number of providers that we have, the number of providers in each county. And we have the total, I hope this is readable, we've got the total physicians and non-physicians. So we do see that there seems to be a bit more variation in the non-physician offices. So that may be something that is driving some of the effects that we are observing. But while of course we're using within county, and this is not within county, we just wanted to try to provide some evidence that we are observing changes. These offices do open and close to some extent, so we have some variation with which to hopefully identify some treatment effects. Yes?
Where does a community health center get counted?
Not in these codes. I'm going to return, when I mentioned later, there are specialty facilities. My understanding of the codes and reading about where I think community mental health care centers are, I do not think that these are in the offices. They're in another code that's, I don't know, specialty mental health and substance use disorder treatment facilities. But as far as I can see, they're not in the codes that we're looking at. That's a good question. Yes?
Just trying to think about a couple of things that are going on in your time period. And I don't quite know where my questions are. One, if you could speak to, you spoke a little bit to psychotropics, and those medications just got a lot better, and there was a lot of innovation in those, and then they got prescribed a lot more. And I don't know if that I don't know enough about this. My guess is that that's mostly the 1990s, but it may be also the 2000s. So it just may be that the whole model of mental health treatment changed, and so like as you said, sort of these complementarities. The second question I had was, this is a period, and again maybe a little bit earlier, but a lot of urban gentrification. So there might be a story about Brooklyn is a great place to live now, and so physicians' offices open in places that used to not be commercial, and of course there's a correlation with. Yes. I assume with the different all the state and your fixed effects and so forth, you may pick up some of that.
I will show you some hopefully maybe some useful falsification exercises to see that we look at something, it maybe measures like economic activity or gentrification. We cannot replicate these findings. we have
Okay.
different findings, but we can, so I think that's important. I think that you're right that there was these major advancements in psychotropics over the 90s, but talking to healthcare providers who are, I work with a psychiatrist, and they're, even to this day, there are still changes in sort of combining the medications, off-label use, learning that some medications that we thought were effective for one particular illness are also effective for other illnesses. So I think this is just, I think my sense is it's a continuous change. This was a major advancement that occurred in the 90s, but the field continues to evolve. I think, maybe I'll show you something in falsification test later that may be somewhat supportive that's not just
I'll
gentrification.
give you my wackiest story of all.
Okay. good.
Marijuana legalization. Like
Yeah.
when you walk along Venice Beach, there's all sorts of little tiny doctor's offices saying, come in and tell us you're depressed and we'll tell you how to get married.
So,
Does it hold up without California?
so yeah, and well, it was, and that's sort of the tail part of this, but it wasn't just California, and a lot of the the medical marijuana came before recreational marijuana, and so is my story really wacky, or
no, I
is
think,
there something to that?
I mean, Joe is certainly the expert on medical marijuana laws. I will say we had medical marijuana laws in the model because we thought they might be important, and we got a bunch of pushback, so we could take it out. It didn't seem to make any difference. So I think that could presumably be going on. But to the best that we've been able to control for it, it didn't seem to have a big influence on our effects. Yes, was it?
Me?
I thought you, did I say?
Yeah, I did. I was wondering, a lot of colleges at universities now have counseling and mental health.
Yes.
Is that included in any of this?
No, not
We do.
Yeah, based on my understanding, the way I read the codes, those are going to show up in another set of codes, which numbers I am forgetting, but they are more like facilities for, they are larger facilities for mental illness and substance use disorder. And I'm going to show you some results, trying to replicate some work later, but I do not believe that they are in these codes. Yes.
There's a correlation between the physician office expansion for physicians who are not mental health and physicians who are. In some sense, I'm thinking of a counterfactual. To what extent are the mental health physicians correlated with the non-mental health physicians? And it's
That's a good question.
mental or general access to healthcare. Your story would be stronger if you didn't see a correlation on the others, but did with the mental health.
Yeah, so I think that's a really good question, and I just wrote down that we should look at that. I do think that there is, and we have another paper that's completely unrelated to this paper, and we've actually looked at spillovers from primary care to mental health care, and we do see, and the mechanisms are less straightforward. So I think that there is some ability to potentially treat mental illness in primary care, but we could definitely have a look at that. We have not yet. Yes.
Going back to the medical marijuana, does your paper or any papers that you've written before talk about the effects of people getting off of opiates or opioids onto medical marijuana, the economic benefits of that?
I have not looked at that, but I think there have been others who have looked at this. David Bradford, who I think may have visited in a previous time, he has looked at sort of substitutions between medical marijuana and a range of mental illness medications, opioids, medications for anxiety. So I think at least people are seeing some substitutions. So the idea that now you have medical marijuana, previously you were using opioids to manage for example, your chronic pain, and now maybe you've substituted with medical marijuana. So I can't claim any, but I wish I'd written those papers. I haven't, but other people have written them, and they're very good. So they're across, I think this has been established in Medicare, Medicaid, private insurance. Jason Hockenberry has also done some work in this area. Okay. So these are our main findings. So I'm going to show you several tables, but this is I think the next 3 slides are the main ones, and I did talk a little slow, but this is the main point, and the rest of it sort of is robustness check. Although I do hope to get to this falsification test that I mentioned, that hopefully I'm not building up too much. So what I'm showing you here are regression tables. I'll explain to you how the tables are set up. All the tables that I'm going to show you look like this, unless I say something else. So all we have here is we have total crime, violent crime, nonviolent crime. We have the mean here. In each cell, this is from a separate regression. What I have is the beta coefficient, standard error, Then we've got the stars that mean what they normally do. In the top row, this is when we combine physicians and non-physicians, and then we separate out physicians and non-physicians. So this is what all of the tables are going to look like, unless I say otherwise. And we control for all of the variables that I mentioned in when I showed you my difference in difference model. So these coefficients, what the beta coefficient corresponds to a 1 unit increase in the number of providers. The coefficients are quite small. We scale them to say what is the effect of I interpret them to what is the effect of increasing the number of providers by 10 in a particular county. So this would be a non-trivial increase. But if that was to occur, we would see about a 4.7% reduction in the number of total crimes, a 2% reduction in the number of violent crimes, and about a 0.25% reduction in non-violent crimes. So what we're seeing is these are not large increases, not large decreases in crime. You might think maybe the violent crime borders on not tiny, but we are thinking about a relatively big dose. So this is another 10 providers in a county. So this goes back to Joe's question about who is induced into treatment and then reduces their crime following receiving treatment. These are probably people who are not overly disordered. They do not have the most severe mental illness. So what we're seeing here is we're seeing declines in crime for people who are arguably not the most high risk for crime. So we think that this is an important spillover that may not have been recognized when we're thinking about office-based care, which is a setting in which patients are often more likely to prefer to receive care rather than going to a specialized facility. Now, of course, some individuals may require care in a specialized facility. We're just talking about these types of providers or these types of patients. What we also see is we see that the declines seem to be driven by non-physicians. So these are the providers who are not prescribing medications. Now, there may be some interplay between with psychiatrists. So this was somewhat surprising to us, and we have a number of hypotheses as to why that might be. I was going to save it to the last slide, but just in case I don't get there, we're thinking that it may be that again, the type of patient who seeks to receive care in these settings, the non-physicians may simply be more effective in reducing their crime and improving their mental illness, and in turn reducing crime outcomes. Also, the non-physician offices, from what we can see in our data, we have very messy data on the number of employees. The non-physician offices are substantially larger, about 1.5 times larger than the physicians. So it may be simply a dose-response relationship. It may be that we think that there are more providers in the non-physician offices, so when that office is closed, there's actually a larger dose in the reduction of treatment. It could be a cost-based story where different types of patients who are more likely to benefit from treatment are receiving treatment from non-physicians. But this is really something that we're trying to think about because we were somewhat surprised. Another concern or another hypothesis that we have is, as I mentioned earlier, medications do themselves have side effects. So it may be that some of the side effects from physicians maybe offset some of the benefits, at least when we're thinking about crime, because some of the side effects can include aggression, hallucinations, other factors that might predispose you to crime. But this is definitely something that we are working on. But in many of these, when we're looking at total and violent crimes, we still do see a negative sign. So perhaps we just have, it's a power story. As I showed you in my variation over time in the number of providers, we do have more variation in the number of non-physician offices than physician offices. Yes.
Is there any descriptive information out there on kind of like the demographics of these people that seek these different types of treatment?
I think in general, I think that those with potentially more severe disorders are going to see the physicians, but that's something we want to build into the paper more. Yes.
Just maybe following along those lines. So there's another reason why I would think that physicians with mental health, and maybe where Bob's and maybe your falsification test too, is the age composition. So elderly, a county becomes more elderly, they're less likely to commit crime.
Yes.
Right? They're more likely to be victims of crime.
Yes.
So that might counterbalance. I have a hard time when I think about the results of whether, it's the victim versus the perpetrator, because presumably for every event, there's at least one criminal and one victim.
Yes.
So it's
Yeah.
hard to see where they.
Yeah.
Yeah.
I think that's true, and we really would. We'd love to unpack this more and see is it the victimization or the offenders, but haven't really come up with a great way to do that at this point. We thought about victimization surveys, but we're not really sure if how much that is going to help us. We do have age controls in here at the county level. If that makes you feel a little bit better, that age is probably not driving all of our findings. We're adjusting for that, but there's still.
I think it might be nonlinear that the more teenage ruffians you have, and the more
Yes.
elderly folks you have.
That's true. That's true. Maybe that interaction
but
between the two.
elderly would drive physician, both
Mhm.
both mental health and non-mental. By looking at like as a falsification test to look at the number of physicians,
Mhm.
Non-mental health physicians might kind of give
Yep.
give me more confidence that it's the mental health aspect, not necessarily an age aspect driving it.
Yeah, and we could do that. We do have that information. We can definitely have a look at that. Thank you. Yes.
So I have a hypothesis on the non-physician physicians, going back to what Andrew said, that
Okay.
we might be able to sort of trace out. He sort of said, well, you lots of people sort of go to a non-physician first who says, well, you need to go to a physician. So you just may be getting the referral, right? Like, so the initial effect is the non-physicians, and when physicians come in, these people have already been seen by somebody else, right?
Yes. Yeah.
So, and in terms of the falsification, I think Bob's idea there is really clever. I would think about dentists.
Dentist?
Yeah.
Well, because you get a lot of dental offices, so they should be opening and closing.
And they're criminals.
Well, I'll show. That could be. I'll show you what we have. We don't have dentists.
So I was sort of thinking dentists or eye doctors or physical therapists as analogs to physicians and non-physicians in terms of having offices that
Yes.
open and close. But again, I'm 2 slides ahead of you.
That's okay.
So-
No, well, these are perhaps better suggestions what I'm going to show you, but these are I can take these home. That's a great idea. So what I'll just quickly do is I've got 2 more slides where I'm going to break this out into specific types of crime. Then I've got a bunch of robustness checks that if we don't have time, that's fine. What we see here is next going to look at the break these out by specific types of crime. And here, first, what I'm showing you is in tables have the same format. We're looking at violent crime. So we are going to look at murder, rape, aggravated assault, and robbery. We combine murder and manslaughter just due to small sample sizes. And what we do see is that we're seeing more evidence of declines in crimes when there's an increase in the number of physician offices. These effects are non-trivial. I think they're about a 2% decline when we're looking at increasing the number of providers by 10 in a county for murder, but roughly the same size for aggravated assault, and the robbery I think is maybe about 4% increase. So these are somewhat larger. It may be that the null effect here, sort of when we aggregate it together, sort of muted some of these effects, but we are seeing more evidence that increases in physicians, the number of physicians' office are leading to reductions in these violent crimes. And again, similar pattern for the non-physicians. When we look at property crimes, so we are going to look at burglary, larceny, and motor vehicle theft. We're seeing similar declines, and these appear to be driven by the non-physicians. We're not seeing as many changes when there are increases in the number of physician offices. So next, I'm just.
You have drug crime?
No, we don't have drug crime in here. We could add it, but I think we opted to focus on the part 1.
Well, because it would go against the decline, the prescription of opioids and things like that, driven drug-related crime. But that would be the other direction.
I can think about that. We haven't looked at it here. Yes.
For the county level analysis, would you consider breaking down between like non-metropolitan and metropolitan counties? Maybe not in terms of crime rates, but in terms of access to care. Like some people might maybe not have access to insurance, like in non-metropolitan areas.
Yes. And also one thing, this is something that the authors have debated amongst ourselves, and you can see who won, those who thought the county was the right level to do this, and we have followed the literature. My big concern is I think this might be too narrow of a network. of a market. So what we also do is we aggregate to the state, which might provide, this is perhaps not ideal either, and the slide is later. And what we're concerned that some counties simply don't have providers. And when we look at our data, there are a number of counties that do not have providers. When we aggregate to the state, we still see similar patterns. When we also exclude those counties without any providers, the results seem to hold. Yes.
I had one more question.
Oh, also cutting by urban rural, which I think maybe you're talking. I think it's a good idea too. Yeah.
Spatial.
Oh, I'm sorry.
No. My students should be saying spatial. You have spatial lines.
No, we don't have
I
spatial
mean,
lines.
I was coming back, like, when you consider bordering counties, like, is it possible to have some sort of spillover effects where people move to bordering counties? Sometimes, it could be because of maybe stigma, you do not, you want to maybe go to a bordering county maybe because of cost reasons or,
I think it's a great idea. I think it's a great idea. I think all of these stories, which are very true, are very plausible. Might be difficult to tease out. We were starting to move down that way with aggregating the state, but haven't done it yet. It's on the to-do list. We're thinking about sort of just constructing measures of border counties and seeing, how many facilities are in border counties, like how many counties have a facility, something like this to kind of get at the fact that you may be traveling across the continent. So I think it's a great idea. We just haven't done it yet, but I think it's a great idea. Okay, I better hurry up because I have 10 minutes. So I'll just show this very quickly and then I'll skip over a few slides. What I do for several things is I look at, we do some robustness for when we look at physicians and non-physicians combined, and then when we separate out, just in terms of to save time, I'm just going to focus on where we look at the total physicians. Although I will say the total number of providers, physicians do not hold up as well, at least at this time, to all of the robustness checks that we're doing. So I'm not trying to hide it. It's in the paper, it's in the slides. I'm going to go over that kind of quickly because I have 10 minutes. So what we're trying to do here, and we're also trying to think of some potentially better ways to do this. We want to try to provide some evidence on parallel trends. So we are estimating a variant of the standard difference in difference model. We've got a continuous treatment with different locations changing their treatment at different times. So we don't have the indicator of the 0-1, which would lend itself to a nice, pretty event study graph. So what we have done so far is we've followed some other literature with continuous treatments, and we've estimated a lead lag model. So what we're doing is we're just augmenting our main model that I showed you earlier. We're just going to we're going to include a 2-year lag, 1-year lag at the contemporaneous measure, and a one-year lead. So ideally what we'd love to see is that the coefficients on all the leads are small in magnitude and statistically indistinguishable from 0. What we see is in our total crime and our nonviolent crime, we generally see the pattern that it seems to be that the effects that we're picking up are at the 1 lag, at least as we have specified this model. We do see some evidence when we look at the violent crime model. We do see some evidence of policy endogeneity. We're still thinking about this. It may be, if we comfort ourselves, perhaps our coefficients still hold up on the lags, but we do see some evidence. As I mentioned, you have to think about why these facilities are opening and closing. It could be due to market level demand or supply demand factors, and this is potentially some suggestive evidence that we may need to think more deeply about how we're modeling at least the violent crime. But we are comforted that many of our main coefficients are holding up relatively well. So I'm just going to do the same thing for physicians. As I said, we do have potentially some oddities in when we're looking at the violent crimes for physicians. We see a positive coefficient of the contemporaneous measure of providers. So we're thinking through this, but our mean point estimates are generally holding up. Now, next what we want to do is, so far we've been treating a crime as a crime as a crime, and we're thinking about from a social cost perspective, that's perhaps not true. If we think about the social costs of crime, it tends to be the violent crimes that are the most costly to society, and many crime scholars have argued that potentially the costs of enforcement or reducing property crimes or nonviolent crimes, they may not be cost effective. But certainly we could think about the violent crimes as being worth the cost of preventing them. So what we do here is we follow a recent paper by, I think I'm probably going to say his name incorrectly, Coffin and McCrary, and we're going to use their cost adjustment. I can definitely show you the equation. I think it's in the paper. Essentially what we're doing here is we are upweighting the violent crimes and downweighting the non-violent crimes based on the cost to society. So this is making the cost that we think the crimes that are more costly to society, we're giving them a bigger weight. So this is just a cost of crime adjusted estimate. Other than that, the model is the same as I showed you earlier. And what we see here is we see potentially that if you compare the coefficients to the sample means, the marginal effects are pretty similar, but we are finding more evidence that the physicians, increases in the number of physicians' offices leading to statistically significant declines in crime. And we think this is because the most costly crimes are the crimes that, when I separated the violent crimes into specific types, these are the crimes where we saw the largest declines when we opened up physician offices. These are things like murder and aggravated assault. So we see when we weight the crimes based on their cost to society, we are finding more evidence that potentially there's more of a role than was revealed in our main estimates for changes in crime following increases in the number of physician offices. We also want to look at suicide rates. So what as I showed you with our arrow diagram, we think that reduced mental illness is potentially a pathway. So we have from increases in the number and access to treatment and our outcomes. So what we do here is we just look at the suicide rate. We use the CDC vital statistics data, and we just look at declines in the number. We look in the number of suicides, and we see increases in the number of physician offices. So these coefficients are quite small. I think they're, when you compare them to the sample means, they are a little bit smaller than our mean point estimates, which are like about 0.2% decline. However, this is only one measure of mental illness, and it's arguably a very serious measure of mental illness. It's a completed suicide. So I think we're going to try and incorporate some more data from potentially the BRFIS, the Behavioral Risk Factor Surveillance Survey, and look at the number of days in bad mental health. Yes?
This is, or these are equations, or this is a equation with suicide on the left hand.
Yes, the outcome here is suicide rates.
Right. So, I mean, it seemed to me as I thought about suicide, it could also be a measure of the level of mental illness in the county. Yes, it could be. Which would put it on the right hand side.
I don't know. I think I'd be a little worried about it. That I think because we're showing changes when we in this outcome, when we see observed changes in our main treatment variable, I'd be a little worried about. I myself prefer more parsimonious models where I don't have any endogenous variables on the right-hand side, but we could certainly have a look and regression adjust and see what happens.
Especially in the violent crime.
Yeah, yeah.
It's just I either can take it out on you or take it out on me.
Fair, fair. I think I saw another hand. Yes.
Do you have data for suicide attempts, like maybe failed ones that they were hospitalized for?
We don't have it. I mean, one can get this data. We don't have it on hand, but I think our plan right now, and we could certainly change our plans. We're thinking about looking at this very severe measure, and then maybe looking at something that's almost at the other end of the spectrum, sort of self-reported days in mental health. But we could think about having a broader portfolio. Yes.
So just to that point, you mentioned VRFSS.
Yes.
YRBS, which is the
Yes.
adolescent counterpart of that, does have suicidal ideation.
Yes.
Which could be another thing
Yes.
that could be really interesting for you to look at if you're going to population surveys.
That's on my last. We have another paper.
Sorry.
No. I think that's a great idea. And Monica and I are thinking about exploring some similar measures in the URBs, and we are thinking more about the delinquency measures. But that's obviously not a nice measure. It's a measure that's in the URBs that could be useful for this. So that's a good comment. Yes. Yes.
Going back to Rob and Dennis, I think they have a very high suicide rate, like among professionals, maybe one of the highest.
I'm sorry, what did you say?
Dentists.
Oh, yes.
High suicide rate,
Yes.
my understanding.
I think you're right, yeah.
But my question is, do you have in the background gradations of mental illness, and that physicians and psychiatrists deal with the most severe, and that like you have master's trained mental health people who can't prescribe and so
Yes.
on. So there's some parsing out by degree of mental illness to the different levels
Yes.
of practitioners.
And I think if I'm understanding your comment correctly, I think there could be sorting of patients across the providers, and they may be allocating more severe patients, maybe receiving care from the physicians. I think that may be one way to think about our results.
And do you distinguish between people who have sort of a neurophysical chemical balance versus a behavioral sort of sociological kind of
in our outcomes?
Yeah, I mean, I think of the physicians as dealing more with the biomedical sorts of, I'm not in this field, but there are significant problems if you know somebody that has one is going to see a psychiatrist, you know.
Oh, sure. Yeah.
Versus people who go to master's trained
Yeah.
mental
I
therapists.
think
Very different.
I totally agree with you. I work with a psychologist and I work with a psychiatrist. I'm 100% in agreement with you. I don't know if we can really get into that in the data. It's difficult to accurately measure many of these conditions in reasonable sample sizes, but I think your point is very well taken.
And PhD psychologists would sort of be in between the physicians and all of the master's trained.
Yes, and they would be lumped. They would be in with the non-physicians.
They would be with.
They're non. When you look at the descriptions of what types of providers psychologists are in with the non-physicians. So just moving along really quickly. So this is my small attempt at a falsification test. I'm not sure if this is useful. We wanted to, I think we have better suggestions from you all today, but we were trying to think of what is an outcome that should not at least display the same relationship between changes in mental health care providers and the outcome. So we spend a lot of time, and it's difficult to think about what would be an appropriate falsification test. They're only useful when they're good ones. I'm not sure. I keep tugging this around because I think maybe it has some value. But what we look at here is sort of a measure of what we think is something that's unrelated to mental health and maybe is capturing something like sort of a gentrification story or something else about the county. So what we look at is we look at the number of florists in the county, and we estimate the same difference in difference regression. So we're looking at changes in florists. And we do have some positive signs. We are not replicating our main findings. So we think of this as capturing something like economic activity or some story about gentrification in the area. And we are seeing the opposite, the pattern of results. So we're not replicating our findings. It's not something simply about the economic or we're not finding any evidence here that's just something else that we're picking up through the number of mental health care providers. Yes?
Very, very different if you ran 100 different occupations and found florists positive versus if you said, well, let's pick florists a priori and oops, it turned out to be positive.
They're criminals. They're known as criminals.
Well, I mean, this is one of 100 that you tried, or
no,
you started out saying
we don't have like the RCT like pre-control, like this is what we're going to do, and we didn't list florists, but we looked at, we didn't just run a million regressions. I think that's very bad science, and I do not believe in that and do not do that myself. We actually looked at the codes and we thought, what is something that would not be predicted, what was not going to have the same pattern, and this is what we came up with, and then we ran the regression, and then we got these results. So I can assure you I have not run a million regressions. I have not. So next is another falsification test. I did run a lot of regressions here, and what we do here is we're just doing falsification in time, or in place. So what we're doing is reshuffling all of the number of mental health care providers across the county. So we're taking the number of providers in this county, randomly reassigning it to another county, and so on and so forth across all the counties in the United States. And then we're re-estimating the model. We're doing this 100 times, and we're getting the point estimate. So what we have here, this is our, and what we would expect is if we are capturing a true effect and not just something spurious, we would expect that our coefficients would be outliers in this distribution. And what we have here is this is the coefficient that we estimate when we're estimating regressing aggregate total crime rates on the number of changes in the number of total physicians. This is our point estimate, and what we have here are all of the other point estimates. So we do this for each of our outcomes, and we take this as suggestive evidence that perhaps our findings are not spurious. It seems as though our estimate is an outlier here. So we do that 3 times, and we get the same sort of estimates. We have done a number of other robustness checks and extensions. You all have given me some great comments. This is very early work, so we really appreciate the feedback. And these are things that we have done or we are starting to explore. In particular, we need to do more on this testing of our design. So that's what we've done or what is in the works. And so just to sum up, we're looking at the effects of changes in the number of mental health care providers in a county, and we're looking at the effect on crime. We're seeing when there are more providers, we're seeing modest reductions in crime. But again, this is a secondary benefit. These physicians and non-physicians, they're not fighting crime. They're providing mental illness treatment to patients who are receiving care in office-based settings. So I think this is potentially important. We're also seeing declines in suicide, which is sort of prima facie evidence that maybe what we're finding does roll along that arrow diagram. Effect size are modest, but some of these, the declines that we're seeing in violent crimes, they are costly to society. There's some estimates suggesting that the cost of a murder is like $10 million by McAllister et al. I'm not an expert in estimating the cost of crime, but this is what others have said. We have limitations. We have a lot of limitations in our data. We brought up many in this presentation. I think we'd love to have more information on the providers. Are they for-profits, non-profits? We think they're mainly not for-profits, private offices, but we don't know as much as we'd like to. So I think that's something, I've said a lot of this before. Policymakers might want to think about expanding access as sort of one of the tools in the toolkit of how to fight crime. And we are thinking about some future work by looking at, we're starting to work on looking at delinquency outcomes among children. And I think I've said most of this. I mentioned earlier why we think it might be the non-physicians who appear to be driving our estimates. Have some other really helpful comments that I'll take back home and incorporate. We also want to go back, if you think that tripartite model is useful for thinking about mental illness and crime, we wanted to kind of think about our results. What do they tell us about why there is a relationship between mental illness and crime? Is it financial? Is it an economic story? Is it an intoxication story? Because we're seeing effects across a range of different crime outcomes, both violent crime and non-violent crime. We seem to be providing evidence that is in line with both of those hypotheses. We're not really discriminating, but we are providing support for the two types of, for those two hypotheses for the link. So that is all I have. Thank you very much for your comments.
In your crime data, is it just total crime, or is it, can you break it down by male criminals versus female criminals? And if you can, do you see a difference in the treatment effects between the two?
We have not. Others may know more about crime data than I do. We do not. I do not believe we can do that in our data. There are other data sets that can allow you to get at that. At this point, we've discussed the possibility of looking at those other crime data sets, but we have not yet done that. And I think that one value here is we do have, these are potentially all reported offenses, so we aren't worried about maybe some offenses becoming, being convicted and sort of that endogenous process. So we've elected to focus on the type 1 crimes, part 1 crimes, but we have thought about looking at heterogeneity by demographic. Yeah.
So I know you said you talked a lot about, how you think of like the mental health care market in terms of like its geographic proximity. You may try like labor market area commuting zones. I know there are like county crosswalks with that, so that may be something you can try if you think that's a better.
Yeah, no, I think that's a really good point. That's something we've thought about. Just trying, we are following the literature, but I think that there are a lot of other ways that people have thought very carefully about what is the correct market. And one thing I think about with mental illness is it's a subset of overall healthcare, so it's not really clear to me that even using like a hospital market would be the appropriate tool. So maybe I think it would be something we could easily do to look at these other market structures, and that's something we've been thinking about.
It'd be interesting to try and find this automobile aspect. There's really rich automobile.
I know, we've been thinking about that.
And,
yeah,
there's a whole other set of papers.
Yeah, we have the FARS data, the fatal accident reporting system. We have discussed the possibility of looking at the changes in these facilities, and we just haven't done it yet. Thank you very much. Thank you.